Partnered by Times Influence.
Hello and welcome to Connect Now on Diabetes, a special feature where we focus on diabetes as a disease and why it's impacting a larger number of Indians every year. Now, if you take a look at the definition of diabetes, it's known as Madhumeha in Indian literature, which means excessive urination, which is sweet in nature. Despite this fairly innocuous definition, it's actually a disease that's reaching alarming proportions. Just take a look at some of these numbers. More than 7 crore Indians are impacted by diabetes, of which half are undiagnosed. It's fast climbing up in terms of being the 7th largest killer for Indians. These are just some of the statistics. Let's understand what's behind those numbers. Why is it that Indians per se are falling prey to this disease? And to discuss just that, we have some of the biggest names from the world of medicine joining us here on the show. Let me introduce them to you. I'll start off with Dr. Shashank Joshi, who is endocrinologist at Lilavati Hospital. Thank you so much for joining us. Dr. Hemant Thakkar, cardiometabolic doctor, who is currently with Jaslok, Patia and Breach Candy Hospital. Dr. Uday Jadhav, who's the cardiologist at MGM New Bombay. Thank you so much, doctors, for joining us on the show. I wasn't quite sure how to begin with the issue of diabetes because it's such a huge landscape. We've been talking about it a lot, but one thing that remains constant is that every year, the number of Indians contracting this disease seems to be continuously rising. Now, let me start with you, Dr. Joshi. Why do you think that is the case?
Mainly as Indians, we are thin and fat, and we are becoming more and more sedentary, and we are getting more and more affluent. And what has happened now, there is a sudden switch. So if you look at it, we are the world number 2 in diabetes, and we are predicted to be in 2045 again world number 1, though we want to be the diabetes care capital of the world. Right. So we are thin, but we put in more fat in our body.
So it's basically what you're saying, and let me come to you, Dr. Thakkar, is it's in our genes? I mean, is there something that we can't really do? We are helpless in that sense?
If one of your parents is diabetic, your chances of getting diabetes is 25% more. And if both your parents are diabetic, the chances of you getting diabetes is more than 50%. If you've inherited this, what you can do is take caution, take early caution, use preemptive steps to alter your lifestyle, because diabetes is a lifestyle disorder.
Right.
What you eat, how much you walk, how much you practice, all your do's and don'ts is important.
So if I know that somebody in my family has the disease, that's definitely an alarm bell in my head. But Dr. Javed, let me come to you, because when one looks at diabetes, is it just a disease that's associated with high sugar levels? In that sense, we have a cardiologist on the show. What's the connection between the two?
Well, yeah, it's not just a metabolic disease. We will have to look at all other aspects. If we look in terms of the impact it will have on heart disease, primarily what it would do is it will predispose these patients to develop heart disease much early in their lifetime than you would expect a non-diabetic. So let's look at the complications that it can set in. It's not just the blood vessels of the heart. It also affects the pumping function of the heart, the muscles of the heart, and the heart attack incidence that we see in diabetes.
So clearly the heart is something that comes under a lot of stress when you have diabetes. But you know, one thing,
diabetes, not heart alone.
right?
If you imagine sugar blood flowing through every cell of the body,
So it's like a corrosive acid.
it is. It's whether it's
It is like
kidney,
white
eyes, muscles. It's percolating into every cell and every nook and corner of the body.
So when you hear it this way, Dr. Joshi, yet the numbers keep rising. And what's really alarming is that half the people actually don't even know they have the disease.
Precisely, because it's a silent killer, and most people with diabetes, it eats your body like white ants, and you don't even know that it has eaten you up. And it affects every cell of our body, as Dr. Thakkar said. But what Uday said is, diagnosis of diabetes is equal to heart attack. But when somebody gets a heart attack, there are 20 people around them. Somebody gets diabetes, they are not 20 people around him. Everybody gives advice on lifestyle, and that is not right. Diagnosis of diabetes is equal to an heart attack. It is an acute myocardial infarction equivalent.
Is it really, aren't we being a little alarmist, Dr.
In
Thakkar?
fact,
Absolutely
if
not.
you have
In
diabetes,
2003,
yes.
ADA, the American Diabetic Association and American Heart Association called diabetes an heart attack equivalent. So therefore, when you get diabetes, the risk of you is the same as that of a heart attack patient.
But let's come to those who are pre-diabetic, and that's a double the number that I just said.
Absolutely.
What do you exactly mean by being pre-diabetic?
Pre-diabetic, which means their sugar ranges are more than the normal range, but they are knocking on the doors of diabetes. They are obese, they probably have insulin resistance, they have glucose intolerance, and they are likely to get catapulted into diabetes. In fact, a pre-diabetic also has a higher chance of cardiovascular dysfunction and disease as compared to a normal individual.
So supposing, Dr. Jadhav, a 25, 26-year-old watching this show gets himself or herself tested and finds out he or she is pre-diabetic and says, I'm going to hit the gym from today, I'm going to cut out all carbs and, total lifestyle change. Will that be enough for me to stop getting?
Absolutely. There has been already a proof on this about a couple of decades back. So there was a study called as the Diabetes Prevention Program, where they prescribed patients on lifestyle modifications with the dietary restrictions. On the other arm, they gave them a very important medication called metformin, which can delay the progress of diabetes. And then the other arm had patients who were prescribed intensive lifestyle modifications.
So which one did the
The
best?
one with the intensive lifestyle modifications, one could postpone diabetes for quite a long period of
So you
time.
said postpone. So Dr. Thakkar, let me come to you, because does it mean that today, if I make a drastic lifestyle change, I can actually hold the disease back indefinitely,
Well,
even
you
if it's
can
there in my
delay the
genes?
onset of disease. For how long, you don't know, because it's like genes which you have inherited. You can't take them to the laundry and wash them off. You can delay the onset, and even when the onset occurs, it would be a softer onset. So I am not taking away from the merits of lifestyle modification. But
Right.
having said that, the patient has sooner or later to accept and not procrastinate medication. You see, there is something like karma, metabolic karma. Sugar in the body, the longer it stays, the more it and the more intensely it damages the cells. So if you need therapy, don't procrastinate it. Start it early. In fact, studies have shown that intensive treatment early in the life leaves no metabolic legacy.
Dr. Jadhav, let me come to you. When you say intensive lifestyle, how realistic is it when you have, say, a young patient or even a patient in their mid-30s coming to you and saying that, I want to keep this disease at bay or maybe even reverse it?
So it's just not happening. I mean, as medical professionals or as a community, we just tell people to keep the diet restrictions and have the exercises. And, most of the people go for a 30 minutes walk, but that's grossly inadequate. That's not intensive lifestyle modification. You will have to look at, you will have to look at calories.
Let's be realistic.
Right.
Theoretically speaking, you can reverse it with 1 hour gym, 1 hour walk, not eating this, not eating that. Diabetes is a way of life. It's in your genes. It's in your metabolism. So you have to give him elbow room to live like a human being. You can't put him in an isolated, extrapolated atmosphere of only exercising and only eating. So you have to fit it in. You have to fit it in with lifestyle, with drugs when and if required immediately, no procrastination, and drugs which do not produce the so-called side effects of the tug of war between high glucose and low glucose.
Right.
Because once he starts treatment, he has problems of hypoglycemia, which is low sugar, and hyperglycemia, which his wife and his doctor bothers him about.
Right.
So choice of drugs, practical and pragmatic approach, along with proper exercise and diet. You have to allow him to cheat. All of us do that.
The Indian patients love to cheat, but we cannot encourage them to cheat.
Isn't that too much of a generalization? Do Indian patients really love to cheat across the board
I
when
think
it comes to their own
patients
health?
and human beings across the world love to cheat. Let me put it that way. But having said that, in diabetes, we are not going to be having a very aggressive approach. You need to eat less. You need to eat on time. You need to eat slowly and you need to eat right. You don't have to give them high-tech diets. You need 10,000 steps a day. You need to sleep on time. You need to sleep well. You need to sleep adequately with a smile. That's all you need. You don't need something which is intensive, high tech, don't do this, don't do that, because when we do things in a very enforcement way, then we fail. I think you need to engage our patients, make them motivated. See, the most important thing is motivation.
Right.
And if you are able to motivate a patient that diabetes is equal to a heart attack and I need to look after myself, a self-motivated patient can actually reverse his diabetes
But
and
we've
stay
been
long.
sending out this message, and there's been a lot of literature out there. So I want to ask the question: are Indian patients motivated enough, or
Yes.
do we have to help them
We
cheat
have role
the
models.
disease?
We have to
You
be.
see, the dialogue between a patient and the doctor is extremely important. Today, patients have to realize that the doctor is the qualified person, not the neighbor next door or the aunt living in the next lane. You have to follow pragmatic approaches. And if you as a doctor, and the inertia is on the part of the doctor also, as much as it is on the part of the patient, you have to engage the patient in prevention, what you can avoid and what you can do. Like I said, diabetes is a way of life.
Right.
The grandfather had it, the father has it, his young son has it. So the ladies in the house, if they don't have it, they can cater to it. You have to allow them to live within their sugar restricted circle, but live well.
On that note, let's head towards a short break. You're watching Connect Now on Diabetes. We'll be back with more. Welcome back to Connect Now on Diabetes. We're in the midst of a very animated discussion about diabetes, its challenges and solutions. Let's continue on that thought. Now, let's talk about those stressed out patients. So, stressing the doctors out, stressing themselves out. Dr. Jadhav, once I have contracted the disease, what are my options now, as opposed to, say, what my grandfather had? Do I have more options now on the table?
Absolutely. I think the science has changed so much. If you look at the medications that have come in the recent, let's say, 4 or 5 years, we had two classes of drugs that came. One was called as DPP-4 inhibitors, and the second, which is an absolutely novel way of looking and treating at diabetes, is using a class of drugs called as the SGLT2 inhibitors.
Right.
So what this drug do is they filter out the sugar in the urine. They reduce the amount of sugar that gets absorbed across the kidneys and they filter it out. Besides this, these drugs have a wonderful heart protection efficacy. So in fact, if you look at this class of drugs called as the SGLT2 inhibitors, and one of the drugs has got approved in the United States and across the world,
Right.
called empagliflozin, what it does is that it protects from cardiovascular deaths. So heart attacks are prevented, heart failure incidence goes down very significantly, and that's a big thing that never happened in the old
But
days.
are these
When we
drugs-
were medical students, I remember 30 years ago, we used to have patients coming to our OPD. साहब ऐसी कोई दवा निकालो कि मैं शक्कर खाऊं और पेशाब में शक्कर निकल
और अब वो
जाए.
ड्रग है.
और वो ड्रग आ गया है. That pipe dream has come true. The first class of anti-diabetic agents to be approved not for cardiovascular neutrality but for cardiovascular protection. So if you have a drug for cardiovascular protection,
Even kidney.
no matter how much it costs, आप patient को जल्दी दे देंगे. If you give it to him early, he can reap the benefits of cardiovascular and kidney protection for a longer period of his
Are
lifetime.
these new age technologies being used enough? Is there in that sense some resistance either from the patient or the doctor side?
Not really. Now I think these drugs are getting more and more popular and they are being used more and more, because you see the other side effect apart from what Dr. Thakkar mentioned is low sugar attacks is also weight gain. These drugs, when you pump out the urine from your glucose from your urine, cause weight loss, and that weight loss causes blood pressure loss, improves the function of the kidney, protects you from heart disease. So these have multitude of effects, these SGLT2 inhibitors, and they are now available in combination also. So you can combine a gliptin with actually a SGLT2 inhibitor.
It almost seems like a magic pill. Are you saying I can
You're giving
continue
him
with
more
my
elbow
diet?
room. You're giving
You
him
can't
more
continue
elbow
your
room.
diet.
Sure about
You
that.
can't
No,
continue
you
your
have
diet,
to
ma'am.
keep all those
You need to
things.
understand there is no substitute to lifestyle.
Okay.
But we can aid and make a modern, high-tech Indian a little better and little quicker with good evidence. And they do
I
very
want
well
to
in our
say
population.
not modern high-tech Indian. I want to say every Indian. Why can't all my Indian diabetics reap the fruits of early modern treatment so that they live longer, their heart is protected? I don't have to then tell him, "Ke bhai, if you take this drug like insulin, you'll put on weight. But you need to lose weight." So if I give an SGLT2, he will lose weight and control his sugars. Let everybody reap the benefits of these new drugs. I'm not saying discard the old, but a good judicious combination will allow the patient to milk all the benefits of modern medicine.
So how open are patients to this new line of treatment? Because when I come in, I think, oh, it's a lifestyle disease. Why do I need to spend so much? Is cost an issue? Dr. Jadhav, what's been your experience?
Oh, it's been very good. I think the reception to this new class of drugs has been excellent. And let me, as a cardiologist, add one very important point, because we deal with heart disease in middle-aged elderly people. This class of drugs is known to cause the minimum incidences of low sugar, what we call as hypoglycemia.
Which is the biggest side effect?
To the human heart, hypoglycemia is as dangerous and probably more dangerous than high blood sugars. So when there are lesser incidences of this low sugar, these patients have lesser incidence of heart attacks and angina and irregular heart rhythms. So if you look at these consequential benefits that occur, and then the weight gain, which is lesser, and the cardiac protection, and we explain them to the
So
patients.
all in all,
They are
there are clearly a
motivated.
lot of benefits. But
Cost of the diabetes is not in the treatment of diabetes, it's in the complications. If you get an angioplasty done from Dr. Jadhav or a bypass surgery done, that is very expensive. But the drug treatment is actually much more economical.
So it's
if
an
you-
investment.
it is-
You have to tell the patient that the drug that you are spending for now, which is apparently seemingly looking expensive, then he is not investing well. Because if he takes this for 5 years, he will not land up in the angioplasty room or in the kidney specialist dialysis unit.
okay, but what about, typically one thinks that one has time. I'm only in my mid 20s to early 30s. I have time. I don't need to go to the doctor yet.
So no. So it's called as ticking clock hypothesis. Your clock starts ticking 10 years before you get diabetes. And therefore, once your clock has started ticking, it's like a ticking time bomb. So when you have got diabetes, your heart is fired, your kidney is fired. It's like whiteheads inside your body.
So why are people, why
Because
is
of
the
education.
age profile changing?
Because of the education, no, because we have become affluent very fast and we have become sust and must and sedentary very fast. And therefore, we need to switch gears. We need to be physically active. We need to.
Two-thirds of Indian diabetics already have coronary vascular disease, they don't know it. That is called asymptomatic cardiovascular disease.
It's not only the genes. Genes and family history is important, but it's the waist circumference. If your waist circumference for a man is above 90 centimeters or for a woman is above 80 centimeters, you are as high as a risk, independent of your family history disease. So a lot of people tell me, my father, mother,
So
grandmother.
regardless of age?
Yes,
even if I'm in my 20s?
Yes, absolutely.
If you have apple-shaped obesity, which
Or
means
truncal
you're not
obesity.
walking, you're just eating and enjoying all the fried bhujiyas, the samosas, what have you, then you're in trouble. Because this is a lifestyle achievement which you have, where you're tucking it in. And as he rightly said, the Indian gene allows him to store fat in his tummy, which produces insulin resistance. He may be thin otherwise, but he has that pot belly. And that's what's breed diabetes.
And that bot belly can be easily taken care of. In the good old days, our ancestors had Kapalbhati. They used to just put the abdomen inside. And all you need to do is burn your fat in your stomach. That's all you need to do. That's lifestyle.
So let's now talk about, a lot of us are trying to lose weight, and this whole issue of insulin resistance and, trying to go back to the whole lifestyle issue and at what stage do I take drugs? And here I'm again addressing the younger population because, as I said, the age profile is becoming
Don't
more and
call
more
it
young.
drugs.
Right.
At what stage do you take assistive medication to bring your sugar down? When you
Okay.
say drug, the patient gets scared.
Absolutely.
After he's done adequately feasible lifestyle modification, beyond which he cannot sustain, he could do it. For the first 2 months, in order to impress his doctor and family, he could do it. But he can't sustain it. That's when, and his sugars are not reaching target, Begin early, so there
Hit
is
hard,
no
hit early.
legacy. Begin with the best drug in its fullest dose early. I'm sure Dr. Jadhav will
Yes,
agree.
I agree with it. I will probably think on the same lines. One should not look at the age. If medications are required, one should get off this myth that all medications are harmful. I mean, if you need to treat all
And
these
Indians are notoriously
notorious,
pill adverse.
notorious. We all, as a community, we
Procrastinate.
all are notorious. I mean, we want
Right.
to keep away from medications for heart disease, for cholesterol, for diabetics. But then this non-communicable disease have such a big impact on the quality of life and life expectancy. So, I
Right.
mean, we have a responsibility towards
See,
our
lifestyle
families.
and preventive pills are married with each other. You really, I call them preventive pills. And these pills are going to prevent you from sinister complications. And therefore, you need to integrate them with your lifestyle.
Okay.
So they have to be married with each other. They cannot be separated out.
Okay.
So which is why if you have numerically less pills, it helps the patient. So if you have a combination which is fitting in well, the patient does not feel the pill burden and he reaps the same benefits.
Okay, this is a fascinating discussion, and clearly it's given me a lot of food for thought, and we really hope it's given our viewers and our audience members as well. Just quick closing comments from each one of you, because every year on World Diabetes Day, we look at the numbers getting even more alarming as far as India is concerned. What's your one-step prescription that you would advise?
Eat less, walk more, hit hard, hit early.
Diabetes is easily controllable, complications are preventable, everything is in your hands. Look at it well and work positively to it.
Dr. Jadhav?
Motivate them for exercises, and as a physician, I would want to be a role model for that.
Great, gentlemen, it's been a pleasure. Thank you so much. So that was it at the end of the special series, Connect Now on Diabetes. We hope that it's helped you learn a lot more about the disease and how to be proactive and keep it at bay. We'll be back with more such features, but for now, thanks for tuning in. Thank you.
Thank you.